Welcome to a deep dive that takes us right to the heart of a problem that can be incredibly scary for pet owners. Those moments when a dog or cat's heart just, well, pauses.
Yeah, it's quite alarming.
We're talking about two specific related heart rhythm issues today: sinus arrest and sinus block.
That's right. We've got a stack of material here, some pretty comprehensive guides used by veterinary specialists that really uh, pull apart the details of these conditions.
Okay.
Our goal is to navigate this material together, kind of cut through the complexity and give you the absolute key insights.
So you should walk away with a clearer picture of what's actually happening inside a pet.
The heart's primary natural pacemaker, yeah. It sits up in the right atrium. And its job is basically to spontaneously generate electrical impulses regularly.
And that impulse then spreads through the heart muscle.
Exactly. It spreads across the atria first, and that creates the P wave you see on an ECG.
Okay.
Then it goes through the AV node, down the conduction system, and bam, into the ventricles, causing them to contract. And that's your QRS complex.
So normal sinus rhythm gives you that predictable pattern, P wave, then a QRS, P wave, QRS, repeating regularly.
Precisely.
Got it. So bradyarrhythmias are just heart rates that are, well, inappropriately slow for this situation. And sinus arrest and sinus block are specific types that come from that SA node, involving pauses or like failures in its activity.
Yes. And it's really crucial right up front to distinguish these pauses from simple sinus bradycardia.
Oh, okay. How's that different?
Well, sinus bradycardia means the SA node is firing and conducting normally, but it's just doing it slowly. The rhythm is still regular. Yeah, just below the expected speed for that animal at that moment. And that could be perfectly normal, like when a pet's deeply asleep or maybe due to certain drugs or even in highly athletic animals.
Okay, so bradycardia is slow but regular. Sinus arrest or block, though, that's about disruptions, those actual pauses in the rhythm.
Correct.
Okay, let's dive into sinus arrest first. What is it?
So sinus arrest, according to these sources, is a temporary cessation of SA nodal activity. Basically, the node just stops generating impulses for a bit. It stops firing.
Stops firing. And what's the key thing on an ECG that flags it as likely sinus arrest?
The major giveaway is a pause where you see no P waves and therefore no QRS complexes follow.
Makes sense.
And crucially, the length of this pause is not an exact multiple of the normal beat-to-beat interval, the PP interval that came before it.
Not an exact multiple.
Right. The sources often say it's longer than twice the normal interval. But the key is that its duration feels kind of irregular, almost random compared to the underlying rhythm. It doesn't fit neatly.
So the SA node goes quiet, and the length of that quiet period doesn't line up perfectly with the previous beats. The underlying problem, the pathophysiology, is a failure of the SA node's automaticity, its ability to just generate that spark.
Yes, exactly. A failure of its inherent impulse generation.
Now, this is where it gets really interesting because the reasons why the node might stop firing are incredibly varied. The specialist guides seem to emphasize that increased vagal tone is the most common transient cause.
That's a super important point, absolutely. The vagus nerve normally acts like a brake on the heart rate.
Right.
So anything that overstimulates that nerve can slam the brakes on too hard and cause these pauses.
Like what kind of things stimulate the vagus nerve that much?
Well, the sources list quite a few examples. Severe GI, upset, vomiting, diarrhea, respiratory issues like heavy coughing fits or the kind of labored breathing you see in brachycephalic, those flat-faced breeds. Even irritation around the eyes can trigger the oculocardiac reflex. Also, certain central nervous system diseases, significant pain, and definitely some anesthetic drugs, especially opioids.
And the key there is transient. If you fix the underlying trigger, like stop the vomiting or manage the cough, the pauses might just go away.
Potentially, yes. That's the hope with vaguely mediated pauses. But the sources also detail intrinsic SA nodal disease.
Which means the problem is actually in the node itself.
Right. The node is damaged or diseased. The guides mention things like degenerative changes, fibrosis, scar tissue replacing the working cells, or inflammation like myocarditis affecting the node area. Even nearby tumors could impinge on it.
And this intrinsic disease is a big part of sick sinus syndrome, SSS, right?
Yes, it's a key component. SSS often involves multiple issues with the SA node, including arrest.
Okay, so it can be an external influence like the vagus nerve or damage to the internal spark plug itself. What about blood chemistry, electrolytes?
Oh, electrolytes are critical to check, especially hyperkalemia, high potassium.
Why is that one so important?
Because the material specifically flags this. Severe hyperkalemia can cause something called atrial standstill. And this looks remarkably like severe sinus arrest on an ECG trace.
Atrial standstill, what does that actually look like?
Well, in atrial standstill, the atrial muscle cells can't depolarize properly because of the high potassium.
Yeah.
So you get absent P waves.
Just like sinus arrest.
Exactly. And often, the QRS complexes might look wide and bizarre too. It's a classic mimic. The sources mention potassium levels over about 5.7 middle EQL, starting to be a concern for this.
Wow, okay.
Severe hypokalemia, low potassium can also sometimes play a role, but hyperkalemia is the really big one to rule out quickly because it's treatable.
That's a crucial distinction then, and certain medications can also cause these pauses, right? Suppress the SA node.
Yes, definitely. Drug-induced arrest is another reversible cause the guides highlight.
What are the usual suspects?
Common ones include beta blockers, calcium channel blockers, digoxin, and certain sedatives like alpha-2 agonists. If a pet on one of these develops pauses, you've got to consider drug toxicity or maybe just oversensitivity.
Got it. Any other potential causes mentioned in the guides?
Briefly, yes. Things like hypothyroidism can contribute to slow heart rates generally. Cardiomyopathies, especially if they cause severe atrial enlargement, which can stretch and damage the SA node physically. Myocarditis, inflammation of the heart muscle, and neoplasia, tumors near the node, are also on the list.
So a really wide net of possible reasons for that node to just stop firing. What kind of signs might a pet actually show if they have this condition?
Well, the clinical signs really depend heavily on how long the pauses are and how often they happen.
Right.
Very short, infrequent pauses. The pet might show absolutely no noticeable signs, completely asymptomatic.
But it's the longer pauses that cause the problems. The sources mention some thresholds for concern, like 4-6 seconds in dogs, 3 seconds in cats.
Exactly. When the pauses get that long, that's when you start seeing signs of poor blood flow, especially to the brain, cerebral hypoperfusion.
Leading to
The classic and often most dramatic sign is syncope, fainting, or collapsing.
scary for the owner.
Very. You might also see just general weakness, lethargy, maybe the pet doesn't want to exercise anymore.
And if these pauses are happening repeatedly, and maybe alongside other SA node issues like really slow rates or even bursts of fast rhythms, that's the picture we often call sick sinus syndrome.
Correct. That constellation of signs points towards SSS. And the guides do note that in cats, specifically, severe sinus arrest seems less common as a primary SSS thing, and more often a consequence of significant underlying atrial disease, usually cardiomyopathy causing the atria to get really stretched out.
Interesting difference in cats. Okay, so that's sinus arrest, the node stops firing, causing an irregular pause. Let's look at the other condition, sinus exit block or SA block. How is this one different?
This is a key distinction, though sometimes, honestly, subtle on the ECG. In SA block, the SA node is generating an impulse. It is firing.
Okay.
The problem is that the electrical impulse fails to get out of the node properly to activate the surrounding atrial muscle. The exit pathway is effectively blocked.
Like a gate being closed.
Sort of, yeah.
Yeah.
The signal is made, but it can't get through the gate.
The sources mention classifying this into degrees like we do with AV block, but they also say first and third degree SA block are really hard to spot on a standard ECG.
Precisely, because you can't directly see the SA node firing inside itself on a surface ECG. You only see the result whether a P wave appears or not. So for practical purposes, we primarily talk about second degree SA block as the type we can sometimes recognize.
Okay, second degree. And within that, there are types like Mobitz type I or Fenkebach. The theory being a progressive PP interval shortening before a dropped beat.
That's the textbook definition, yes. Progressive shortening, then a pause that's less than twice the preceding PP. But UT, and this is a really critical point highlighted in the literature, reliably identifying Mobitz type ISA block in dogs is extremely difficult.
Why is that?
Because dogs normally have respiratory sinus arrhythmia.
Ah, the breathing variation.
Exactly. Their heart rate naturally speeds up when they inhale and slows down when they exhale. This normal variation in the PP interval makes spotting those subtle, progressive Venkebach changes incredibly hard to do confidently. It just gets lost in the noise.
Right. The normal variation kind of masks the pattern you're looking for. So the more useful type of second degree SA block, the one that really helps differentiate it from sinus arrest, is Mobitz type 2.
Yes. This is the key distinguishing feature for Mobitz type 2 SA block, when you can identify it. The pause duration is an exact multiple of the preceding normal PP interval.
An exact multiple.
Yeah. So if the normal PP interval between beats was, say, 1 second, the pause might be exactly 2 seconds long. meaning one beat was generated but blocked, or exactly 3 seconds long, 2 beats blocked, a 2.1 block or 3.1 block, and so on.
Okay, so the ECG hallmark for recognizable SA block, type 2, is a pause, no P or QRS, but the pause length is a precise multiple of the normal beat interval right before it. But again, caution needed in dogs because of that sinus arrhythmia.
Absolutely. It's a key diagnostic point in theory, but needs really careful measurement and awareness of that normal variability.
Yeah.
The pathophysiology here is about impaired conduction from the node outwards.
Are the underlying causes different from sinus arrest, or pretty much the same?
Generally, the causes are very similar, as the sources list the same culprits. Increased vagal tone, intrinsic SA nodal disease or SSS, drugs like beta blockers or digoxin, electrolyte imbalances, hypothyroidism, cardiomyopathies, myocarditis, neoplasia.
Why so similar?
Well, it makes sense because many conditions that damage the SA node's ability to generate impulses can also easily damage its ability to conduct those impulses out to the rest of the atrium. The same disease process can affect both functions.
All right, so arrest, node stops, irregular pause, and block. Node fires, but impulse gets stuck, pause is often a multiple. They're closely linked, share many causes, and can look very similar on an ECG, especially in dogs. Let's talk about how pets present and how vets actually diagnose these.
Sure. Clinically, the signs are essentially identical for both sinus arrest and sinus block. As we kind of touched on, it all depends on how long those pauses are and how often they're happening.
So ranging from completely asymptomatic, if the pauses are short and rare, all the way to those dramatic signs like syncope, collapse, weakness, lethargy, exercise intolerance, especially if the pauses cross those thresholds like 4-6 seconds in dogs, 3 seconds in cats.
Exactly. And yes, the potential for sudden death from a very prolonged pause, a long period of asystole, is unfortunately mentioned in the material as a risk.
What might a vet pick up during a physical exam?
Well, they might feel a slow heart rate, bradycardia, either consistently or maybe just intermittently. The pulse might feel irregular, and sometimes you can actually palpate or feel those pauses where a beat is skipped.
Okay.
There's also an interesting little detail in the sources. They mention that the heart sounds, when you listen with the stethoscope, might actually sound louder right after a long pause.
Louder. Why?
Because the ventricle has had extra time to fill up with more blood before that next beat finally happens. More filling leads to a stronger contraction and louder sounds.
Huh, that's a neat clinical observation.
Yeah.
So how do vets definitively figure out which of these bradyarrhythmias is happening, or even if it is one of these, and why?
An in-clinic ECG is the starting point, of course. If you happen to catch a pause during that, say, 5-minute recording, you've got direct evidence.
Lucky catch sometimes.
Can be, yeah. And then careful measurement of those PP intervals around the pause is key to trying to differentiate a rest, not a multiple, from block, an exact multiple. Though, again, we have to keep hammering on the difficulty in dogs due to sinus arrhythmia. You might also see escape beats on that ECG.
Escape beats.
Yeah, if the pause goes on long enough, sometimes a lower part of the heart's conduction system, like the AV junction or even the ventricles, will sort of take over and fire off a beat just to keep things going. They escape the pause. They usually look different and are slower than the normal beats.
Okay, but often these significant pauses are intermittent, right? They don't happen conveniently during that short clinic ECG. So what's the essential tool then, according to these guides?
This is where the Holter monitor or ambulatory ECG becomes absolutely essential. Cannot emphasize that enough.
The take-home recorder.
Exactly. It's a small device the pet wears, usually for 24 hours, sometimes longer, while they go about their normal activities at home. This is how you capture those intermittent or infrequent pauses that you'd otherwise miss.
And what does the Holter tell you?
It quantifies the problem, how many pauses, how long was the longest one, what was the heart rate doing the rest of the time, and crucially, it allows you to correlate the electrical activity with the clinical signs the owner is hopefully recording in a diary. Did the dog collapse right when that 8-second pause happened? That's gold standard information.
So the Holter confirms that the pauses are happening, how bad they are, and if they actually line up with the symptoms. What about looking at the heart structure itself, or blood tests?
Absolutely necessary. Echocardiography, a heart ultrasound, is also crucial.
Why?
You need to look for any underlying structural heart disease.
Yeah.
Is there cardiomyopathy? Is there severe atrial enlargement that could be stretching and damaging the SA node? Echo also helps rule out other potential cardiac causes of collapse.
And blood work seems vital too.
Oh, absolutely vital.
Yeah.
You must rule out systemic causes. And we keep coming back to it, but hyperkalemia has to be checked, especially if you see severe bradycardia and maybe absent P waves because of that atrial standstill mimicry. Thyroid levels are important too. checking for hypothyroidism. And naturally, if the pet is on a drug like digoxin, checking the serum levels is essential to rule out toxicity.
There's also a specific test mentioned in the material, the atropine response test, or RT. What's the purpose of that?
Its main purpose is to try and help differentiate pauses that are primarily caused by that excessive vagal tone we talked about, from pauses caused by intrinsic irreversible disease within the SA node itself.
Okay, how does it work?
Pretty simple, really. You get a baseline ECG recording first, then you administer atropine, which is a drug that blocks the effects of the vagus nerve on the heart. After giving the atropine, you'll record the ECG again and see how the heart rate and rhythm respond.
And how do you interpret the results?
Well, a normal response is a significant increase in the heart rate, ideally back towards or into the normal range for that animal. This strongly suggests that high vagal tone was the main culprit, because the atropine blocked it and the heart sped up. An abnormal response is when there's little to no significant increase in heart rate after the atropine. This suggests the SA node itself isn't capable of speeding up properly, pointing more towards intrinsic disease. The material does caution, though, that the test isn't perfect and can sometimes be a bit inconclusive.
Right. They're not always black and white.
Yeah.
And finally, just gathering the basic information signalment like breed and age, and getting a really detailed history of the collapse events from the owner. That's obviously super important too.
Absolutely. Knowing you're dealing with, say, a miniature Schnauzer with collapse is a huge clue right away, given their predisposition to SSS, which often involve these pauses. Getting the details of what happens during an episode is key.
Okay, let's quickly touch on the differential diagnoses, other things that might cause similar signs or ECG findings that you need to rule out before landing on sinus arrest or block.
Yeah, it's important to consider other possibilities whenever you see a slow heart rate or collapse.
Like simple sinus bradycardia, which we said is slow but regular, unlike the pauses we're discussing.
Right, or atrioventricular block, AV block. The key difference here, if you can see it on the ECG, is that in AV block, P waves are still happening regularly. The SA node is firing, the atria are depolarizing. The problem is the signal isn't getting through the AV node down to the ventricles properly. So you'll see P waves marching along, sometimes without a QRS following them. You don't see P waves during the pause in sinus arrest or SA block.
That's a critical ECG difference. And we mentioned atrial standstill again, often from severe hyperkalemia where the atria don't depolarize at all, mimicking severe sinus arrest.
Yes, crucial to differentiate. A vasovagal syncope is another differential.
The fainting reflex.
Kind of, yeah. It's a neurocardiogenic issue, basically, an exaggerated nervous system reflex causing sudden severe bradycardia or even a brief stop, often coupled with blood vessel dilation leading to collapse. It can be really tough to distinguish from primary cardiac causes unless you happen to capture an ECG during the actual event.
Tricky. And then, of course, you always have to think about non-cardiac causes of collapse, things like seizures, maybe severe low blood sugar, hypoglycemia, and drug overdoses or toxicities.
Exactly. Ruling those out, or in, is all part of the diagnostic workup.
Okay, let's shift gears to treatment. Once you've diagnosed sinus arrest or block, how are these conditions managed?
Well, for the acute situation, if a pet collapses, often the episode is self-limiting, meaning it stops on its own and they recover fairly quickly.
Okay.
But if you have severe persistent bradycardia or even a systole that's causing ongoing collapse or severe weakness right now, then IV atropine can be used as a temporary measure to try and increase the heart rate.
Like an emergency boost?
Exactly. And absolutely critically, if a reversible cause has been identified like that severe hyperkalemia or an overdose of a drug like a beta blocker, then addressing that immediately is the top priority, correcting the potassium, stopping the drug.
Makes sense. What about long-term management? If you fix the underlying cause, like treat hypothyroidism, does the heart issue resolve?
It certainly can, yes. If the pauses are clearly linked to something treatable like hypothyroidism, managing the thyroid condition might completely resolve the bradyarrhythmia. That's the ideal scenario.
But what if the pauses are severe, causing clinical signs like syncope, and they aren't due to an easily reversible issue like in cases of intrinsic SA node disease, SSS? What do the sources say is the best approach then?
For symptomatic patients with severe, irreversible sinus arrest or block, the gold standard treatment, according to all these specialist guides, is the implantation of a permanent electronic pacemaker, PEP.
A pacemaker? Just like people get, what exactly does that device do for the pet?
It essentially provides a safety net, a reliable minimum heart rate. It constantly monitors the heart's natural rhythm. If the rate drops below a certain programmed level, The pacemaker kicks in and delivers a tiny electrical impulse, usually to the ventricle, to stimulate a heartbeat.
So it prevents those dangerously long pauses.
Precisely. The VVI type is most common. It paces the ventricle, senses the ventricle's own activity, and inhibits pacing if the heart is beating fast enough on its own.
And what's the outcome usually like for pets that get a pacemaker for this?
The prognosis is generally excellent. The material really highlights that pacemaker implantation is highly successful at completely resolving the clinical signs, like syncope. It dramatically improves the pet's quality of life.
That's fantastic.
Yeah, and the long-term survival with a pacemaker is typically very good. It's done less commonly in cats than dogs, partly because the underlying causes can be different, but it's reported to be equally successful when indicated.
What about trying to manage these conditions long-term with just medication? Is that a viable option?
The sources are pretty clear on this. Medical management generally has limited efficacy compared to pacing, especially for severe signs. It often provides only temporary or partial symptomatic relief, and it doesn't fix the underlying electrical problem.
So when might medication be considered?
Well, perhaps for patients with very mild or infrequent signs. Or maybe if the cost of pacemaker surgery is prohibitive for the owner, or sometimes it's used as a sort of bridging therapy while waiting for pacemaker implantation.
What kind of drugs are we talking about?
Usually oral medications that are aimed at trying to speed up the heart rate. Things like anticholinergics, maybe propanthenol bromide, or beta-agonist drugs like terbutaline, or sometimes medications like theophylline or aminophylline are tried.
And what are the downsides or limitations mentioned?
Oh, quite a few. Significant limitations and side effects are noted. These drugs often require very frequent dosing, like multiple times a day, which can be tough for compliance.
Right.
And they can cause side effects like dry mouth, constipation, sometimes nervousness or excitability. And paradoxically, they can sometimes cause unwanted rapid heart rates, tachycardia, which can be problematic too.
And there's a specific challenge mentioned for pets with bradycardia tachycardia syndrome.
Yes, it's a particularly tricky situation. That's where a pet has both the dangerously slow pauses and episodes of abnormally fast heart rhythms, often atrial fibrillation or supraventricular tachycardia.
Double trouble.
Exactly. Because the drugs you might use to try and speed up the heart during the pauses can make the fast episodes worse. And the drugs you'd use to slow down the fast rhythms would make the slow pauses even slower and more dangerous. It's a real catch-22.
A pacemaker seems much better suited for that situation then.
Definitely. A pacemaker ensures a minimum safe heart rate, and then you can potentially use medications more safely if needed to control the fast rhythms without worrying about causing severe bradycardia.
Okay, so it sounds like the surgical option the pacemaker offers a much more definitive and reliable solution for severe or symptomatic cases where reversible causes aren't found or fixed.
That's the clear message from the specialist literature, yes,
Yeah.
for symptomatic, non-reversible cases.
Let's think about the overall prognosis and what owners really need to understand. Without any treatment for a pet that's symptomatic, experiencing collapse from these pauses.
The prognosis is generally considered guarded to poor. Those syncopal episodes aren't just frightening. They indicate a significant problem with blood flow, especially to the brain, and there's always a risk of a pause becoming prolonged enough to be fatal.
But with a pacemaker.
As we discussed, the prognosis becomes excellent for resolving those clinical signs and giving the pet a great quality of life. Good long-term survival is expected in most cases.
And just relying on medical management.
It's really variable. It might offer some temporary or partial help for some individuals, but it generally doesn't stop the underlying disease process, like SSS, from progressing. And it often doesn't reliably prevent severe signs, like syncope, from happening again.
So client education here is absolutely vital. What are the key things owners need to grasp?
They need a clear explanation of what's actually happening, that the heart is literally pausing. Understanding the difference between arrest and block might be less critical for them, but the concept of the pause itself is key. If sick sinus syndrome is suspected, they need to understand its potentially progressive nature. They should definitely understand why a pacemaker is considered the definitive, most effective treatment for severe symptoms compared to the limitations and potential side effects of long-term medications.
What else?
They need to know what signs to monitor for at home, like frequency of weakness or collapse episodes. And they absolutely need to be aware of the increased anesthetic risks involved if their pet needs sedation or anesthesia for any diagnostic procedures or surgery.
That brings us neatly to those special considerations, particularly anesthesia.
Yeah, this is definitely a high-risk patient group for anesthesia. Pets with pre-existing sinus arrest or block are much more prone to developing profound bradycardia, long pauses, even a systole, and low blood pressure when they're under anesthetic agents.
Which anesthetic drugs did the sources flag as particularly risky?
The guides specifically mention avoiding or using extreme caution with alpha-2 agonists, high doses of opioids, propofol, and potent inhalant anesthetics, as these can all further suppress SA node function or significantly increase vagal tone, making the bradycardia worse.
So, intense vigilance during any anesthesia is absolutely required.
Oh, absolutely.
Oh.
Continuous multimodal monitoring ECG, constantly watched, invasive blood pressure if possible, capnography, it's all paramount. And having emergency drugs like atropine and maybe even isoproterenol drawn up and immediately ready to go is non-negotiable.
Temporary pacing might even be needed sometimes.
For very high-risk patients or potentially long procedures, yes, placing a temporary pacemaker catheter might be considered to ensure a safe heart rate during the anesthesia.
Okay. We've touched on predispositions, but let's just highlight that again because it's such a strong link in some cases.
Yes, it really is. The miniature schnauzer is the poster child, unfortunately, for sick sinus syndrome, which commonly manifests as sinus arrest or block.
Any others frequently mentioned?
Other breeds listed in the sources include West Highland White Terriers, Dachshunds, Cocker Spaniels, and Pugs seem to pop up quite a bit too.
And again, just to reiterate that difference in cats.
Right. In cats, it seems less likely to be this idiopathic SSS picture and much more often secondary to significant underlying atrial disease like hypertrophic or other cardiomyopathies, causing that physical stretching and damage to the atria and the SA node region.
So the cause might differ between species, even if the ECG rhythm looks similar.
Exactly. Understanding the likely underlying cause influences prognosis and sometimes management.
Let's circle back one last time, just because it's so important, to hyperkalemia. The sources really emphasize ruling out high potassium because it can mimic severe sinus arrest via atrial standstill.
It truly cannot be stressed enough. If you see a small animal patient with severe bradycardia, and especially if the P waves seem absent or hard to find on the ECG, checking a potassium level is one of the most critical first steps.
Because it's potentially fixable.
Exactly. It's a potentially rapidly treatable cause of a very scary-looking and dangerous heart rhythm. You don't want to miss it.
And finally, when is referral to a specialist, a cardiologist, generally recommended for these cases?
Consultation with a board-certified veterinary cardiologist is highly recommended, really for most of these cases, especially if they're symptomatic.
Why?
They have advanced expertise in interpreting complex ECGs and Holter monitor reports, especially differentiating tricky rhythms. They can help determine the best diagnostic plan, including advanced tests if needed, and critically, they manage treatment decisions, especially planning and performing pacemaker implantation, or navigating those really challenging situations like bradycardia tachycardia syndrome.
Wow, okay. We have really gone deep into sinus arrest and sinus block today. We started with that really scary picture of a pet collapsing.
Yeah.
And now we've navigated the subtle but actually quite important electrical differences in how the SA node can malfunction, either just stopping firing altogether in arrest or firing but having the impulse blocked from getting out in SA block.
And we've explored that incredibly wide range of potential causes, everything from, simple transient vagal reflexes triggered by common things like a cough or some GI upset,
Right.
all the way to serious, progressive, intrinsic degenerative disease of the heart's own electrical wiring, like in sick sinus syndrome.
We've seen how those pauses, once they get long enough, directly translate into those dramatic clinical signs, especially syncope. And we've covered the key diagnostic tools, highlighting that absolutely essential Holter monitor for catching intermittent events, and the main treatment options, really emphasizing the definitive benefit of a pacemaker for severe, irreversible cases compared to the often limited utility of just medical therapy.
So hopefully you now have a much clearer, more practical picture of these specific heart rhythm issues, why they happen, what they look like on an ECG, and what really goes into diagnosing and managing them effectively in our canine and feline patients.
Absolutely. And as you think about all this we've discussed, maybe consider how conditions that originate from something as fundamental as the heart's own natural pacemaker can have such incredibly varied causes.
Yeah, it's fascinating.
It could be something as simple as a nerve being stimulated by, say, a tummy ache or a coughing fit, or it could be complex degenerative disease affecting the heart's fundamental electrical system itself.
It really highlights how interconnected all of the body's systems are, doesn't it? And how sometimes To really fix a seemingly straightforward problem, like a slow heart rate, you have to look far beyond the heart itself. Unless, of course, the heart's own fundamental wiring is indeed what's truly broken and needs that pacemaker support.